but what happens when the decision involves many other people and many other values and many other contexts that not only affect organic bodies, such as our body or an organ in a specific, and then becomes a social or cultural and sometimes a legal matter that has to be discussed. The main thing that I want to talk to you about is all of this framework that is related to the therapeutic relationship. How do physicians and healthcare givers are having this social and very close relationship, and how is that bioethics, when it's born in around 1979, questions the traditional model of this relationship. It's about questioning how the health professionals are making these very, very important decisions. It comes to the point of public health, and it is also related to the products, the drugs, and the pharmaceutical enterprises that we have all around the world, and what is their primary role. So you have the first one that is, I would say, the most traditional one, when either if you are a patient or you are a doctor, or you're a doctor who's a patient sometimes. So you have a model that is based on activity and passivity. There has to be an active subject, which is mostly the doctor, and a passive subject, which is mostly the patient. So how do we see it? You know, how do we face it every day? So basically, it's a relationship that is very much like a parent-infant relationship. So mostly the physician, the doctor, even the students will try to educate the patient, to explain the symptoms that the patient is already having, and to try to explain why is this happening, how is this happening, when sometimes it is a bit more of a learning experience to actually hear how is the patient experiencing the illness, how this pain is changing in his life or her life, and how that can give the physician and the professional a different context of what is going on. And that will help a lot in the decision-making process. So this is the first one. The second one is more of a parent-adolescent kind of relationship. So you will have not only as an activity-passivity model, but you will have some sort of a guidance. And this is very interesting because sometimes patients will be expecting you to tell them what to do, you know, so when to take the medicine, how to conduct themselves in work or in their family life, or actually including how would you feel about what's going on, how to react to the illness. And this is very interesting also because when we go to medical school, we have a very limited knowledge of what happens to the body. I mean, you can explain physiology, you can explain anatomy, you can say how maybe a virus is damaging some organs on your body, but you cannot actually say how does that feel? How is that going to change your life forever? Or if you're going to be enabled to do the things that you would do earlier before that illness would come to place. So this is a guidance cooperation. And this is very interesting because those three models that we are looking right here are some sort of power-based relationship. Either somebody has power and the other one is expecting to receive information coming from that place, you know, privileged place, and the other one is using this power in terms of always trying to make the best for the patient. So this is also a very interesting thing because sometimes when you talk to patient advocacy groups, you listen that then may think that we as doctors abuse power. Sometimes that is true, but it's not the objective, it is not the aim of how medicine should be and it's conducted. And then we have the third model, which is a more participant and a partnership. It's when you actually have an equal relationship, when everybody is at the same level, and you as a healthcare giver understand that the patient is an individual and that has autonomy and that has liberty to make decisions, to make choices. And also you understand that it is actually more that you can learn from the patient that actually you can teach the patient. So it's a very cooperative kind of relationship with, it's a win-win situation for everybody. And this is the most difficult one because the educative system in medicine actually relates in the first one traditionally. And the second one, it's a bit more of a challenge of thinking about a new way of teaching medicine or teaching healthcare sciences. This is the characterization of the paternalistic model. This is what we have right now. This is in Latin America, in Ecuador, when I have practiced medicine for a very long time. You can see that this is a model that it's very, very much inserted in what we think about medicine. So what is the role of the doctor? Dominance, authority. It's about egos. It's about, tell me how big your white robe is and I can tell you how big of a doctor you are. The older you get, the more power you will have and the less questioned you would be. So we arrived to the autonomous model, which is something that bioethics promotes a lot, because as you remember in the Geneva Declaration, you have an amazing and very important respect for autonomy. And this is very interesting, and I want to tell you a little story about what they call the parents and the fathers of bioethics, which is two philosophers, that is Tom Beauchamp and James Childress, which actually wrote the Belmont report in 1979. And in one of the interviews with Tom Beauchamp, he was actually asked about which of the 4 principles in bioethics is the most important one. And it's very interesting because it's almost like when you have more than one sibling, you have 2, 3 brothers and sisters, and somebody asks your mother which one is the favorite one. And so with Beauchamp, the question was very much like that. And you know that mothers always respond in a very political way, and they would say, no, I love them, all of them. I love them equally. They are all the same to me. But when you have more than one sibling, you actually know who is the favorite one. So here you have the patient-centered care model and what are the main issues that it's addressing. This is a framework, of course. It has patient's preference. It guarantees or it improves access to care, the information and education. It allows coordination when you have and you are working with different other disciplines. In medicine, it gives the possibility of emotional support, and emotional support not only for the patient, but for the family, for the doctor. You would see that from the pandemic and COVID, you will see all these videos and all these photographs of doctors breaking at the foot of a bed of a patient when it finally expires or when finally dies, and how challenging that is, and how important it is actually to recognize that we as doctors and medicine should be affected when you lose a patient, when you fight for a patient and you actually lose that fight. So the emotional support is very important there. And here you can have, you can see a Universal Declaration of Bioethics and Human Rights, the one that I was telling you about before, the 2005. And you can see human dignity and human rights, benefit and harm, autonomy and individual responsibility, consent, which is very, very important, persons without the capacity to consent, what happened with children, with infants, what happened with elder people, what happens with people that do not speak the same language, the respect for human vulnerability and personal integrity, the privacy and confidentiality, equality, justice, and equity, non-discrimination and non-stigmatization. We still know that there are some diseases that are stigmatized, such as tuberculosis, HIV, COVID. It's one of those. The respect for cultural diversity and pluralism, solidarity and cooperation, social responsibility and health, the sharing of benefits, protecting future generations. We are talking about climate change as we speak, and the protection of the environment, the biosphere, and the biodiversity. So all of these are actually fields in bioethics, all of them. So whenever you are addressing bioethics, you would be actually addressing human rights also.